From the JAMA Network, this is JAMA Surgery Author Interviews. Conversations with authors exploring the latest clinical research, reviews, and opinions featured in JAMA Surgery.
Hello, and welcome to JAMA Surgery Author Interviews. I am your host, Dr. Jamie Coleman. Today, we will be discussing the review article, Nasogastric Tubes, Indications, Placement, and Management. You can find a link to it in this episode's description. We are here with senior author Dr. Zuckerbraun from the Department of Surgery, University of Pittsburgh. Thank you so much for joining us today.
Thanks for having me.
All right, nasogastric tubes, commonly referred to as NG tubes, are tubes that go through the nose and into the stomach. They have been around for centuries and I think have caused every surgeon a fair amount of chest pain at some point in time in their career. So I know this review article is going to be popular, and I'd really love to just walk through the whole thing from the beginning, if that's all right with you.
Absolutely.
All right. Well, let's start with indications. You describe or categorize 3 of them. Can we start there?
For sure. I agree with you. Nasogastric tubes are part of our everyday practice and part of the everyday practice of so many surgical disciplines, particularly abdominal surgeons. And they're so commonplace, I think sometimes we don't take the time to think about, the whys and the whos and the best practices that have evolved. As far as indications, nasogastric tubes are clearly the most far and away clear-cut indication, continues to be small bowel obstruction as the mainstay of treatment when there's not intestinal compromise. And that's almost, if you think about it, indication 1, 2, and 3. And I think that the critical review of the literature continues to really endorse that NG tube decompression is really the mainstay of treatment.
And really helping our patients resolve faster, and especially now, as you reference in your article, with the addition of oral contrast, using these NG tubes in patients who aren't able to tolerate drinking liquids. They're very nauseated. They've got potentially lots of vomiting or emesis episodes happening, but really being able to use these for patient comfort and treatment, I think, is what you really highlight well in the article.
I think the interesting thing is, again, what oftentimes is the reflexive use in other indications, which is post-gastrointestinal surgeries. And that's more controversial as far as where there's really a true benefit. And so writing this review article with my co-authors, I think, was a great exercise for myself to really think critically and revisit some of these indications. And in the setting of the evolution of enhanced recovery after surgery, ERAS protocols, and really challenging some of the paradigms of routine nasogastric decompression after GI surgeries, whether that's gastric surgery, colorectal surgery, pancreas surgery, where I think there still is some unknowns, but clearly it would suggest that routine nasogastric tube decompression isn't necessary after most gastrointestinal surgeries, and that in some cases there might be deleterious side effects, increasing the risks of aspiration events.
Let's dive in there a little bit, because I think you really hit the nail on the head in the sense that NG tubes, we've been around them for so long. Again, the technology is not necessarily new, but how we've used them is changing, has changed, and really should change, right? From, when we all started 20 plus years ago as a medical student, and it was dogma and law and a lot of opinions and high feelings could be associated with the use of NG tubes. And I think that's why this review article is so perfectly timed, because we have had a shift. We have had an adoption and really verification of the literature surrounding enhanced recovery after surgery, or ERAS protocols. And so now's really the time to say, hey, we have the data. Let's actually review it. So let's pick one. This is just a plug to our listeners. You guys have got to actually download and look at this article, because there's there are lots of fabulous figures and tables, but one in particular, table 1, actually goes through the use of NG tubes by operation type. So there's colorectal, pancreatic, gastric, esophageal, hepatobiliary, and gynecologic. And it goes through routine versus selective, considerations for use, and then considerations with EROS protocol. So, you mentioned colorectal, and I think that that's one area in particular we've seen a lot of change. Can we walk through that segment of the table? Is that good with you?
Again, I really think through the efforts based upon enhanced recovery and implementing and learning best practices for our patients. There's really been a push for earlier feeding, avoiding routine NG tube decompression. And we've learned a lot from that. And colorectal is a field where I think if you look at the body of evidence that's coming out in the literature, it tells us that routine use of NG tube decompression seems to be even associated with prolonged recovery and prolonged return of bowel function, which may be just slowing down the practice and unnecessary pause. Or there could be even less understood effects of when you're not allowing the body to do its natural processes and you're changing what normally goes into the gut and what promotes normal physiology, you're preventing that. So I think there's a lot of unknowns, but clearly the evidence is suggesting that avoiding routine NG tube decompression, particularly in colorectal where there's the field from the ERAS perspective and is more mature, that it can be avoided. I learned a lot in writing this even about operations that you consider to be high risk, like pancreas operations, where we know that there's delayed gastric emptying in some pancreatic diseases and pancreatic cancer resections. But again, there's a fair amount of literature suggesting that it can be avoided and that routine use of NG tube decompression delays normal return of bowel function.
And I liked too where you even referenced how it delays our patient's mobilization, which makes sense. We're basically tying them to the bed, and avoiding tubes supports early out of bed, quoting your paper here, on post-op day 0 to 1. And we know that, to quote a favorite fitness instructor of mine, that we come to a point in time where movement is medicine. And so getting people up and moving absolutely helps their recovery. I'd say the other one too, particularly for you and I as emergency surgeons as well, but even looking at the gastric operations where we've got a repair, a suture line or a staple line on the stomach, talking about how NG tubes really should be short term and removed. We're talking early, post-op day 1 to 2. And for those of us that have been in the game for a couple of decades now, right? You went from, everyone had one for a week. We're going to be on top of things here. And we're going to say, we can take it out at day 3 or day 5. But really the literature supports even earlier.
I agree. I think that, and I challenge myself and the field to say, let's look at this body of evidence. Let's move away from routine use and consider it selectively and really high risk, where the preoperative scenario, perhaps where there was a component of proximal or gastric outlet obstruction, and then use good physical examination and clinical progress to determine if NG tubes should be kept or replaced in the postoperative recovery period. Because clearly there are patients that do have delayed gastric emptying, that do have a lot of distension on exam, and we want to prevent vomiting and aspiration risk in that patient population. So there's no substitute for a good daily history and physical assessment, and then really leveraging that for the selective use of NG tubes moving forward in this patient population.
And you mentioned the insertion of NG tubes. I'd like to move there. You've got a great section on this in the paper. Can you help describe for our listeners some best practices, some tips and tricks for the placement of NG tubes?
I'm sure anyone who's placed an NG tube before knows that sometimes it could be quite challenging and uncomfortable to patients, and also can lead to vomiting and an aspiration event. So really thinking about the use of a lubricant, correct angles to avoid unnecessary friction and discomfort to the patient, as well as just ease of placement, having the patient make sure that they're upright, and if they are not obtunded in any way, can really participate, and explaining it to them ahead of time so that they can try to swallow, try to help make sure that it goes through the oral pharynx into the esophagus, not into the airway, making sure there's an assessment for that. By oftentimes you can ask the patient to speak or phonate, you're not going through the vocal cords. And then of course, if you meet any resistance that's greater than the normal, to not persist. The one thing I like is the table that we included as a safety bundle, which gets into not only the placement aspects, but the day-to-day considerations once they're in,
Yes.
like preventing pressure injury, that's something we see, unfortunately, in some of our patients, whether that's on the ala of the nose or on the columella, or from how it's secured, especially when they're used longer terms in some of our critically ill patients. Fluid and electrolyte losses that need to be considered, and then asking yourself on rounds, kind of as part of a checklist, does this need to be here? Can we remove it? And can it be done safely?
Thank you for highlighting that, because it's true. NG tubes help patients and can even save lives. But like any intervention, there can be complications. You've mentioned a couple. And again, I like how you categorized these in another fabulous table. You talk about insertion-related complications and then use-related complications. For use-related, you've mentioned pressure on the nose, and you can even get tissue loss from that. Do you want to talk about or expand on a few more, whether they're insertion-related or use-related? And then also, how can we avoid them? You mentioned bringing it up on rounds every day. What are some other tips that we need to be incorporating?
I do think that with a patient that is NPO, right, they're not eating, we tend to, as a field, we have oftentimes decreased the amount of intravenous fluid we're giving patients. We tend to run them drier as a modern day practice than what we used to. But one of the side effects when you have a patient who's not taking in liquids and they are also have the additional fluid losses from NG tube, we really need to be thoughtful, both from the standpoint of acute kidney injury, volume depletion, dehydration, and the electrolyte losses. So patients don't need labs every day in many clinical scenarios, but you have to be thoughtful about making sure that we're not doing harm in regards to those types of things, which again, there's secondary ripple effects when you're not being attentive to those aspects of care. That's one thing. And then because it's such a common, banal practice, yes. I don't think we check ourselves every day, right? I mean, I
agree.
I think from a safety and quality standpoint, we're often saying, does this patient need this central line? Does this patient need a urinary catheter? And I think we should really put NG tubes right up there. And when they're being used, ask ourselves every day, still necessary? Can we remove it? And if it needs to stay, then do I need to think about the effects on volume and electrolytes, so on and so forth, checking the pressures developing.
Yes.
Because those are the kinds of things that obviously there could be acute effects, but when a patient leaves the hospital with an ulcer on their nose, that bothers them for months on end.
Absolutely. And I think it's just so important, like you said, to bring the same degree of attention and detail to every detail, even the most commonplace ones. Well, thank you, Dr. Zuckerbraun, so much for joining me today to discuss your article, Nasogastric Tubes, Indications, Placement, and Management, a Review. Our listeners can find a link to the article in this episode's description. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com or search for JAMA Network wherever you get your podcasts. This episode was produced by Shelley Steffens at the JAMA Network. Thanks for listening and have a great day, everyone.
This content is protected by copyright by the American Medical Association with all rights reserved, including those for text and data mining, AI training, and similar technologies.